Thank you very much for this kind invitation, and particularly because there is a very friendly way to conduce this Congress. I need to speak about the role of US in suspected pancreatic mass or in suspected biliary mass. And we can see that US and fine needle aspiration is involved in multiple steps. The first goal is understand if the patient is resectable or not, because we know very well that in Italy the surgery probably operate too much patient with pancreatic mass. And we must spend more time probably to study the patient and understand if there is infiltration, vascular infiltration. This data is not true because consider all the study and not use CT scan. But probably CT scan is superior in evaluation of infiltration of arteric mesenteric superior and hepatic artery. Probably US is better to explore, to evaluate the infiltration of portal vein. 3D US is an ancillary possibility. In Italy there is only one machine in Padova, and so probably we speak about the future of this technique, but we cannot propose our patient this modality now. FNA, but when I need to perform FNA? When change my management of the patient, because the important role of ultrasound and particularly of endoscopic ultrasound is in the correct local regional staging of the patient. We must look for the node, the border, the hypoechoic structure, if it's round, if the size is more than 5 millimeters, because the potential role of malignancy in this case is 80%, but unfortunately only in 55% of the node we can see all these features. And sometimes we need to perform USFNA. And so when I study the pancreas, my brain must be prone to perform fine needle aspiration because it is an invasive procedure, the patient is sedated, and I cannot wait 20 days to perform another performance, another biopsy in a second time. But the indication, Professor Varadaragiullo from Birmingham underlined when we must do this. Obviously, to document a diagnosis of malignancy if the patient is judged unresectable, to exclude the other type of tumor, and when a patient or family is reluctant to undergo major surgery without a correct diagnosis, or to document the absence of malignancy when the potential role of malignancy is low, and obviously for neoadjuvant therapy. We can see the clinical impact on US to change the management, because during US we can see a very little node. This is a mediastinal node near the heart, and we can practice US fine needle aspiration. But also during the exploration of the pancreas we can see a little film of ascites and to perform the USFNA for exclude carcinomatosis. Or very important is look for very well the liver to see, as in this case, a very late metastasis, 5 millimeters, and to practice the punction, because this changed completely the management. And the problem of the T, because not all the tumor of the pancreas are malignant, and particularly not all tumor of the pancreas are adenocarcinoma. And sometimes benign lesion could appear like a cancer, particularly pay attention autoimmune pancreatitis in type 1, because the patient is a male and he is usually 67, 70 years old, like adenocarcinoma, and so we must practice differential diagnosis. But the result about USFNA are so good. Probably this data is not completely true, because they are the best in the world in the practice USFNA needle aspiration. But if we look for American study, we see that the accuracy of fine needle aspiration in center not skilled is not so high, sometimes near 10%. And it is a very expensive procedure. One needle costs 400 euro. And so it's very important to have skilled cytologists and not only skilled ultrasonographists. And we must prepare young people in this procedure and respect the supervision of the teacher. Also in the US, we can use new technology. In ERCP, we can use a mini probe, we can see guide wire, to explore the common bile duct to distinguish benign lesion or cholangiocarcinoma rather than pancreatic cancer. Or using elastosonography, particularly for distinguish chronic pancreatitis versus cancer, or contrast enhanced. Particularly, this type of technique has central role to determine neuroendocrine tumor, but probably also in the help in foresee better the target lesion and perform in the good area my USFNA. Another problem is the typology of the needle, because we could adopt also a big needle, 19 gauge, but in the duodenum to approach the head of the pancreas is impossible, because this needle is not so flexible. And so we study the difference between 22 and 20 gauge needle, and there is no difference. Probably the cytologist is more happy with 25 because there is less blood contamination, but at the end is the same. This is a new era for US, because now we have a new needle, and the goal of this needle is to obtain a core for histology, and we can see that the accuracy is very high, but now we have low data. In this work, in this paper, there are only 40 patients with pancreatic cancer. To obtain the core is the best, because we can manage this tissue and apply molecular technique, the dosage of also of KRAS analysis, but to increase the accuracy, not to modify the therapy like in colon cancer. And also to evaluate SMAD4 gene activation, because probably is a strong indicator of aggressivity of the cancer, and in the future will change the concept of resectability. Probably Dr. Bassi tomorrow will speak about this. And also to discover and to perform FNA in a very little tumor in particularly neuroendocrine tumor, because now we could have a less aggressive approach, laparoscopic approach, and using EOS we can put also KINA for help the surgeon during a surgical performance. And I suppose together, hope in the future to have strong, important drug for neoadjuvant therapy like for rectum, because now you know that pancreatic cancer unfortunately is fatal. The modern world speak now about the importance of the screening, because in the pancreatic cancer early is too late. But unfortunately we could use only very expensive procedure like a CT scan, like a RMN or EOS, and the results now are not encouraging. In the second part of my speech, I want to speak about the potential therapeutical role of EOS, and particularly about biliary drain. But we can see that is a very ancillary technique, because few cases are reported in literature, even if EOS indication of American Society of Gastroenterology underline the hypothetical role of EOS in therapeutic approach. And in literature we see a great interest, but the level of evidence now is very low. Only animal research and only case series. But why EOS could have a role? Could have a role because ERCP can fail for duodenal obstruction, anatomical variation, periampulary diverticula, or for the tightness of the stricture in a 10% of cases. Percutaneous approach could have a good result, but not when biliary tract is not dilated, and is not a technique without complication, and also the surgery, especially when the patient has jaundice. So US could have a role. Wirsema, at first, 15 years ago, described the first case of cholangiography using a needle for fine needle aspiration, inject contrast in the common bile duct. I don't want to spend time about the role of EOS in the drainage of pancreatic fluid collection, but it's really true that we need to perform the drainage only when the patient is symptomatic, because are not technique without complication. And I can use transduodenal route or transgastric route to obtain rendezvous, to obtain that the guide wires spontaneously pass through the papilla, or to create a new papilla between the stomach or between the duodenum. The first step is the puncture of the common bile duct after we perform ductography, and after we place a guide wire inside the common bile duct. Someone thinks that probably EOS could have a role when, during ERCP, I must perform a very deep precut, because also deep precut could have complication. And the goal of EOS is that when ERCP fail in the same session, if I have EOS machine and endosonography, I can drain the patient immediately in the same session with the same anesthesia. And as we can see, the result is good about technical success, clinical success, but we have complication. And we can recognize that there are the typical complications: pneumoperitoneum, cholangitis, cholecystitis, and obviously also pneumonia. And we don't have data about the patency of the stent, because when you practice biliary drain using EUS, usually is for palliation, definitive palliation. And so we must choose the best stent. Plastic stent is not so expensive, 100 euro. But when you practice this approach, sometimes we see migration ongoing, and so we need multiple revision. And there is a big question: metallic stent or plastic stent? We have no data, but here is only to demonstrate that we have few cases enrolled in the world, and there are the results about this technique. I want just, and in this case, we can see the biliary tree, common bile duct, and we put the needle through the duodenum inside the biliary tract, and we practice cholangiography using contrast, and we can see the contrast. There is a big stenosis on this side. This papilla was unapproachable because there was duodenal obstruction, and so we put guide wire inside the biliary tree, and now we create a fistula using a pre-cut needle, the same needle of the pre-cut. And it's very easy because it's guide wire, and the distance between common bile duct is 2 millimeters. After, we can choose two different approaches. Or dilation. Air dilation is better if after I put plastic stent, just to tell, this is Biliary. Plastic stent, or in other situation, we can use also metallic stent. And I want to show you this. This is another case. We published this work 1 year ago. This is papilla, and after the pre-cut failed the procedure, so using EUS vein, we can see very well the common bile duct. We approach the common bile duct and perform cholangiography, and after we place the guide wire, and we can see here the guide wire, and after we use pre-cut needle to create a fistula. In this case, we use dilator, the same dilator that we use during the RCP, and at the end we put metallic stent without dilation to avoid migration. And this typology of palliation obviously is definitive. Thank you very much for attention.
Thank you very much, Fabbri. Any questions?
Probably I missed the size of the catheter, the rate of dislocation, and how many did you perform? Actually, you perform when the endoscopic drainage failed. You instead to put a percutaneous, you put a permucosal drainage. And how many transgastric, how many transduodenal, any difference between them? Because probably if a dislocation or a fistula in duodenum or a complication in duodenum could be more serious than in gastric wall. So it's a very intriguing and very, it's a fantastic, it's a Columbo's egg in a way, but actually is fantastic for this kind of patient that not have a short lifespan, and the percutaneous drainage that I often when is indicated perform in this patient is you put it without much enthusiasm, because you know that is a really palliative method. So this is fantastic, but I want to understand how many success rate possibility you have in this case.
Okay. Thank you very much for the question. I need to practice a review for answer all these points. I totally agree with you that is a very ancillary method, this approach. We discuss in the department when we can perform this typology of approach in case ERCP fail. About the technique, I use 19 gauge needle because through the 19 gauge needle pass a guide wire 0.035 gauge, and so I can obtain easily the way to use after other device. The technique is a very long technique because the medium time is 60-90 minutes. Okay. Also because there are very few experts in the world about this technique. The bigger casuistic published enrolled 40 cases from Maranki, okay? And the second casuistic enrolled 18 patients. And we have no data to compare percutaneous drainage with biliary drainage or with transabdominal drainage. So, probably is very important to consider also the setting where you live and where you work, because if it is easy to obtain the drainage percutaneously using transabdominal approach or radiological approach, probably now is better for the patient. And the endosonography could have the intelligence to wait a possibility to practice randomized study.
Dislocation, how many?
Okay, I practice 26 cases, but I publish only my cases using metallic stent because it was a new result. Usually, when you use transgastric approach with plastic stent, you have more migration, and you have more migration because there is a peristaltic movement of the stomach. In duodenum is more fixed the stent, and you have also more complication because using US we can approach only the left lobe of the liver and not the right lobe of the liver, and so it's partial my drainage. Do you understand? And I can have more bleeding because sometimes I need pass through hepatic artery. About metallic stent, as you have seen, in duodenum is very easy to see the common bile duct. Also because in this case, usually the common bile duct is bigger, more than 1 centimeter, and so it's very easy also the puncture.
So at the moment you don't suggest as to push on this technique,
No.
just select the patient. But another question, in my experience, is not just 10%, the rate of failure of endoscopic drainage, but it's higher. Even if you listen for a radiologist, a visual radiologist, Andy Adam, that he says that they never found a stricture that can be trespassed. So, this is my bad experience with the endoscopic drainage. How do you explain it?
Okay. Me too. My personal success is 75% in my published paper, and I agree with you that I don't think it's 90%. Also because I must underline that I'm lucky, because I work in US, but this typology of drainage I perform with my chief, that he is very expert in interventional endoscopy, and we obtain this data helping together in forehand through the scope. And I totally agree with you that 90% is not the reality.
Otherwise, I couldn't see all these patients needing a percutaneous approach.
Yeah. I want to underline that personally, I have not a major complication, but pain and fever that resolved obviously without surgery. Probably, if you are more obsessive, more aggressive, could obtain more result, but we pay more in complication. But in this era, I don't think it's ethical. If you are able to perform EOS drainage easily, it's okay, but in other way, it's better to stop the procedure.
What's your experience regarding focal masses in the head of the pancreas, distinguishing autoimmune pancreatitis from adenocarcinoma? What's your accuracy?
This is a great question. I see only two autoimmune pancreatitis and in the body and not in the head of the pancreas. So I have not experienced, and the major part of cases are reported on the body of the pancreas. So hypoechoic mass in the body of the pancreas in a male, if you are not sure if the very indicated the dosage of IgG4, and also in the young female, because you must think autoimmune pancreatitis, but in this case you are unlucky because IgG4 are negative.
And regarding the differentiation between A.N.I.C.E, which despite the size is benign, from A.N.I.C.E in which there are borderline features or low-grade malignancy?
This is a great question, because when I want to see if I have.
So several times the MRI and they ask for
as you know, there are 3 types of EPM, and when you have a mass, a cystic mass of 3 centimeters in the pancreas in asymptomatic patient, and you see moral nodule, you can approach using fine needle aspiration, but you must know that accuracy of fine needle aspiration in the cystic lesion is very low, less than 15%. There are new data about the use of procore needle because the accuracy is high, but few data. We can practice also the dosage of SEA in the lesion, but is not able in IPMN to distinguish benign and malignant lesion, and so at the end we must use a clinical approach. If the patient is not symptomatic but the Wirsung is more than 1 centimeter, if the lesion is more than 3 centimeters and there are mural nodule, probably the surgical approach is the best. but sometimes the patient are in elderly age with other comorbidity, and so it's not so easy. And probably in the future, the endosonographer and particularly the radiologist could have some field using ethanol or as other drug for injection in selected cases.
Are you any other complication with catheters during biliary or pancreatic drainage, such as stent obstruction, it is true that it is better to drain pancreatic juice or biliary content into digestive tract than peritoneal drainage. But could you solve the problem in the case of the obstruction of the catheter without introducing new catheter?
Okay. In our experience, but in the experience of literature, the obstruction of catheter during the procedure is not described. Also, when we speak about pseudocyst, we approach very large pseudocyst, symptomatic pseudocyst, infected pseudocyst with necrotic debris. And we use the same technique. And also in this case, we put metallic stent, fully covered metallic stent. We publish now in Endoscopy our series in collaboration with I.N.I.C.E from Palermo. And we have not measured complication, and we resolve the case in 1 month, and we have a long follow-up, 11 months. Because it's true that the communication with Wirsung is mandatory to determine the recurrence of pseudocyst. But if you use a big stent, you can have an acute detention of the Wirsung, and so to create the best condition to close the fistula.